Hi everyone, thank you for joining us today and welcome to our 5th webinar in the Keeping It Real series. Today I will be moderating. I'm Anna Richards, Commercial Lead at Vitaccess, and I'm joined by Dr Mark Larkin, CEO and founder, and our expert in patient and caregiver research, Dr Catherine Bottomley, Director of Patient-Centred Outcomes. So over the next 25 minutes, we will take you through why a caregiver perspective is more important than ever in real-world evidence studies. This will then be followed by a 15-minute Q&A session where you can put your questions forward to us. So feel free at any point to add them to the Q&A post that should appear at the bottom of your screen. So if we move to the next slide. And the agenda for today, I'll give you a short overview of Vitaccess, and then Catherine will take us through everything about caregiver perspective. Here you have like why do we collect this data and how do we collect this data, and then Mark will take us through real world examples, and we'll have challenges and tips before moving to the Q&A. So if we go to the next slide. So we are an innovative research organisation. And you can see here we've got these 5 complementary core capabilities that allow us to give a collaborative approach in global digital research. So top left, you've got real world evidence, and then going in a clockwise fashion, you've got analytics, localization, patient-centered outcomes at the bottom here, health economics, outcomes research, and market access. So we move over to the next slide. And we have from concept to implementation, we help generate these real world data and insights through our patient-centric solutions. So you can see here we do this through the our real world platform, Vitaccess Real, which comprises of this data capture tool, so patients can complete questionnaires and other data evidence in their own devices, phones, smartphones, computers. And the real-time research portal that you see on the right, so you can see the data as it's collected. So if you move to the next slide, here you've got the flow from the type of participant data capture, so whether it's a patient, a caregiver, or a clinician, and then the modules in the center of the Vitaccess Real platform that allow for this collection of granular data, and again, the research portal to see the outputs in real time. So that's a whiz-stop tour of us. And I'm now going to hand over to Catherine to talk more about caregiver perspective.
Thank you very much, Anna. Good morning, good afternoon, everybody. So we thought it would be a nice place to start to think about caregiver perspective in numbers. What does the caregiver population currently look like? Who is it comprised of? So we were quite surprised when we saw these data based on a recent Carers UK survey. There are currently 13.6 million informal carers in the UK. Absolutely huge amount. You know, this is a very large population. And interestingly, there's been an increase in 4.5 million caregivers since the COVID-19 pandemic. Perhaps not surprising to many of us. Interestingly, 70% of caregivers reported providing more care during the pandemic. Again, something which we can all see as a fairly obvious consequence. Perhaps not so obvious, but still surprising. 55% of the caregivers surveyed admitted feeling overwhelmed, whether that was overwhelmed by the care that they were providing, their life situation more generally. And so these figures really demonstrate the size of the caregiver population currently. So now just moving on to think about who are caregivers, how do we define them? So caregivers in healthcare research studies are usually defined in a fairly uniform way. They are often described as primary informal caregivers of patients. And what do we actually mean by that? So the primary parts, usually they are people who identify themselves as a main caregiver, somebody who is typically close to the patient, and is providing them with that primary source of care. And by informal caregivers, we usually mean those who are either paid or usually unpaid. So they don't necessarily have to be people who are receiving, for example, carer benefits. They're people who are providing this care without being paid and as part of their role as a family member of this patient. So typically the type of people that we see in our studies, we see close family members, parents, grandparents, siblings, sometimes close friends. And actually, whereas this is a fairly typical definition, some studies broaden this definition to include family more generally. So that could be people who live with a patient, don't see themselves as providing care, perhaps that patient doesn't require care from others, but they can still be greatly affected by various aspects of the patient's disease. I think one of the things that's really key here for us is defining that caregiver population up front in a study. It can determine firstly whether that caregiver participant sees themselves as a caregiver and therefore considers themselves to be eligible, or if you're recruiting caregivers through patients, or perhaps using dyads, so paired coupled patients and caregivers, it's very important for the patient to be able to determine whether they have a caregiver themselves or not. Typically, if you said to a patient, do you have a caregiver? They might think, no, I'm not paying anybody to provide that care. But actually, it's not paid caregivers that we're often looking for. So that definition is really key. It's really key to include, first of all, informal study documentation, protocols, etc. But perhaps more importantly, in any of the participant-facing materials, so eligibility screeners, those types of documents. And then one of the most important questions, why? Why are we interested in collecting caregiver data? Why is it most gaining in importance at the moment? So historically, decision makers focused largely around patient perspective when they were considering disease burden. So what's it like for a patient to live with a particular condition? How do various treatments or interventions change that experience for that patient? But as the number of caregivers increases, the impact on caregivers becomes of increasing interest. And there have been various bodies of research that have been released over the last 5 to 10 years demonstrating the large impact on patients themselves and also the impact on caregiver health. One of my favourite definitions that I've come across in the work that I've done with caregivers is the idea of the greater patient concept. And this is a really nice way of describing the impact of patient disease on those around them. It's a concept that was defined by a group of dermatologists working in caregiver research, and it's called the greater patient concept. So you can see here the map of London in the same way that we have the City of London and then we have Greater London. We also have the patient at the centre, and then we have those around them. So it could be those who are caregivers, it could be those who are family, but it's those people who sit around that patient and who can potentially be impacted by their disease, by their condition. So collecting both patient data and caregiver data and considering that the impact of disease can be felt beyond just the patient can help to build much more of a complete picture of disease burden. And with that in mind, it's fair to say that using an effective treatment and effective intervention could reduce both patient burden and also caregiver burden as well. Although it's not the focus of our discussion today, it's also worth mentioning that caregivers can also be used as proxies for patient data collection. So in particular situations, for example, if a patient is a young child or the patient has a condition which means that they're not able to answer questionnaires or take part in interviews themselves, caregivers can be used in those situations to report on behalf of patients and to describe their experience on behalf of them, because they're typically those who are living most closely to that patient. So what are the components of caregiver burden? What does that data look like that you'd typically be collecting? Well, in the same way that we would approach a patient-reported study, we would look to define the areas of caregiver burden up front. So for each study, we would look at the areas of caregivers' lives that are most greatly affected, those things that are most important to them to capture as part of the data set. You can imagine that this would look quite different for different studies, different caregiver populations, different patient populations. different relationships, perhaps different ages of caregivers. It's really not a one-size-fits-all approach. It can be very broad. Typically, when people think of caregiver burden, they think of quality of life, and we know that quality of life is a very broad concept, but what are the kinds of dimensions within quality of life that we would typically see in a caregiver study? And I've just included some examples here. So we would often hear that caregivers are affected by a huge emotional burden. So you can imagine the worry, the stress of caring for somebody that you love can be absolutely huge for that group of people, particularly in long-term conditions, chronic conditions. That worry can be focused on the future. So caregivers worrying about the patient's future, their own future, the future of them as a family. The next one we have is sleep. So we often focus on sleep as an aspect of data collection in caregiver studies. The emotional burden that I described can feed into sleep. People laying awake at night, worrying, not able to fall asleep. But there are also some physical aspects of caregiving that can feed into sleep as well. That could be things like administering medication, changing dressings, operating equipment, for example, that would cause a caregiver to have disturbed sleep. There are physical aspects of caregiving that need to be considered within a data set. So it could be things like having to lift patients, carrying patients, particular types of machinery, objects, transferring patients from one setting to another. They can have a potentially huge physical impact on a caregiver. Work and finances is another really common one. We see this in a lot of our caregiver studies. The impact on work is fairly well documented in the literature. Typically, we see caregivers reducing the hours that they spend at work. Perhaps when they are at work, their productivity can be reduced. And for many, they actually end up giving up work altogether to focus on the caregiving aspect of their life. Combined with this, we see caregivers often spending their own money. We see evidence of the hidden costs of disease. This could range from having to buy over-the-counter medication and equipment for the patient, adapting homes. There are various costs that are associated with caring for somebody. And you can imagine, again, this is something which varies hugely between different diseases. So if we think about this combined impact of reduction in work and earnings, and then these increased outgoings, you can see that that's potentially a huge issue for this group of people. The next ones are social and relationships. These tend to go fairly hand in hand. Due to caregiving responsibilities, people can often find it difficult to maintain hobbies and interests, meet up with friends, meet up with family, exercise, and the stress and strain of caregiving and all of those various responsibilities can have a huge impact potentially on family relationships with others. So you can see that there's a huge variety of data that we collect from caregivers and huge aspects of their life that could potentially be affected in their roles. It's also worth mentioning here the potential for caregivers to become patients themselves when we think about that greater patient concept that I was describing. Sometimes the burden on the patient could become so great that they become a patient themselves. They acquire related medical needs. Perhaps that's the prolonged emotional impact leading to diagnosis of depression or anxiety. Perhaps it's the physical strain of lifting, transferring patients to muscular injuries. And there's also the consideration around stress as a risk factor for other illnesses. You can imagine here the potential impact on the healthcare resource use, the healthcare system, the cost. And this is an area that's not widely reported or widely understood across many different disease areas. And as well as a sort of awareness from an academic perspective, there's this increased awareness of the importance of caregiver data is also reflected by key stakeholders. So the example that I'll talk to today is around NICE. So in the previous health technology evaluation manual, there were fleeting references to carer data, but in the new updated manual, which has been released over the last few weeks, there is more detailed information that NICE have provided about the type of evidence that they would expect to see in various situations to support caregiver burden. The various references through this manual refer to caregiver data being used as part of burden of disease piece, clinical effectiveness evidence, cost effectiveness evidence. And in particular, NICE say that the evidence should be provided to show that the condition is associated with a substantial effect on caregivers' health-related quality of life and how that particular technology affects carers where relevant. It's also interesting that we now have some more detailed, updated information on the methods that we should be using to collect utility data for carers when we're thinking about using that data as part of the cost effectiveness evidence. So in the same way that NICE previously provided a hierarchy of methods for collecting that evidence for patients, this has now been broadened to include carers as well. And as possibly expected, that has the same type of hierarchy, and it follows the same pattern as those methods that were recommended for patients. So it's really useful for us to have that increased clarity. There's also a new section to this guidance around acknowledging some of the benefits of qualitative research, that it's a potentially useful tool for assessing the impact on carers. And that's really important when we think about some of the methods for collecting data from caregivers. So with that in mind, that takes me on nicely to the next slide. So far we've seen that the caregiver perspective, the caregiver burden can be very broad, it can be multivariate, but the good news is that there's a huge range of established methodologies for collecting this data. And in the same way that when we define the type of data that we're going to collect from caregivers, the way that we collect it is also very specific to the particular research objectives, the situation, the questions that you want to answer, the cohort that you're looking at, and the time and the budget that you have available to do that. So we would typically select the most appropriate research method based first on the study objectives, and we would always recommend starting with at least a look at the literature. So what's actually out there already in the disease area that you're working in. It could be that there is a large body of qualitative research out there, for example. We already understand from that qualitative research what the main areas are that are important to that particular group of carers, but it may be that you then want to quantify that evidence. So your job in designing that study would be to think about the most appropriate questionnaires and the most appropriate methods for quantifying that data. If there's very little in the literature review that comes out of the literature review, and if there's little in that body of literature to describe the topic in more detail, so the why, what are those key areas for caregivers, why are they important, what are the particular examples and scenarios that are important to those caregivers, that's where qualitative research would play a part. So interviews or focus groups for carers to understand their experience in depth. And then, as I previously alluded to, we might then select a questionnaire or a survey to quantify that impact. Particularly important if you're looking for a change over time, you're looking to describe that change, or you're looking to compare that impact across other disease areas. And we have a variety of options here. So they range from standardized, validated questionnaires, what you would typically consider as a patient-reported outcome measure. And a lot of these are for carers are based on quality of life. Or there's the option to add bespoke survey questions, so design questions for that particular study to capture those aspects that you're particularly interested in. And that can be really useful where you are collecting data such as hidden cost of disease. There are other methods available as well. So mixed methods are particularly useful if you're combining qualitative and quantitative data. It might be that you have some quantitative data and there are patterns within that data that you don't necessarily understand. Qualitative data can be really useful to describe and explain some of those patterns. And then in situations where you don't necessarily have direct access to a carer population, or where it may not be appropriate to collect the data directly from them, vignette studies can be used to ask typically general population groups to value descriptions of what it's like to be a caregiver within particular disease areas. So we often use combinations of these methodologies. We use single methods methodologies. It's very bespoke depending on the study objectives and the disease area that you're working in. So just to very briefly touch on the types of questionnaires that are available, this could probably be a webinar in itself, but generally if we're thinking about the standardized validated questionnaires, we would first of all use an evidence-based selection process. There needs to be a very good reason and rationale for selecting the questionnaires that you then take forward into a study. We would typically look in detail at the content of those measures, and also their use in the target population, any development and validation evidence that there is available. Roughly, the questionnaires can be split into 3 different categories. So there are generic caregiver questionnaires, those that are applicable across all disease areas. There are those which are more disease specific. So there is an example in the slides here of a dementia burden scale that's designed for completion by caregivers. And then there's the use of what we would typically think of as patient or person questionnaires. So these are questionnaires that have been designed to focus on one particular aspect or dimension of life, for example, sleep. And these are questionnaires that have been designed or questions phrased in a way that means that they can be answered and addressed by people who are not necessarily suffering from a particular condition themselves. They assess these dimensions on a much more broad level. So that's a few examples. What does a caregiver study look like in practice? So we thought it'd be a good idea to share with you a few of the caregiver studies that we've been involved in recently. So I'll hand over to Mark to take you through those now.
Thanks, Catherine. So I'll take you through some studies really to show some of the variety of methodologies that we've followed. This is a first study, and this is a study which is public. So where public, we can tell you who the sponsor is, and there's some publications attached. So this is a study in cystic fibrosis sponsored by Vitaccess. We've got a cohort of patients starting from 12 plus, and then patients and caregiver proxies for a younger age group, 6 to 11. So obviously we have to tailor the data capture to those patients, those tranches of age, etc., and the consent and data flows associated. So we work with, for all these studies, actually quite closely with key opinion leaders, patients and advocates in the design of the studies. As you heard from Catherine, and as of course many of us know, caregivers have got quite a lot on their plates already. So although we're very interested in very detailed data capture and get very ambitious, it's important not to be over ambitious. So that collaborative approach in the design is really important. So we don't overburden the caregivers in each of the studies. So for this study, it's UK and Ireland. It's a longitudinal study over about 18-month period. And we're able, because we're using digital tools, bring your own device data, digital data capture. We do that very flexibly. So we look at the type of data we're interested in. So demographics, you see another patient-reported outcomes instruments, etc. below. And then we can think about the administration schedules for those different types of domains, which can be quite different. And you see at the bottom, there's a publication. If you in the materials afterwards, you can look that up. We started publishing the data from that study. So if we go on to the next one, this is a slightly different study where it's a cross-sectional data capture. And Catherine mentioned dyads of patients. So we're doing a longitudinal registry study in this rare condition. And we're also capturing data from caregivers linked to the patients who are in the longitudinal registry. So EU5 geography, and in terms of data capture, again, it's pretty detailed. We tried to establish the key parts of the burden on the caregivers in this condition. You see some of the PRO instruments, EP5, D5L, sleep, fatigue, promise, etc., to try and get a better handle on the caregiver burden. Now, what we found is quite encouraging in this type of work is that caregivers themselves are typically very happy to participate in this research, to have it recognized that the really important role they play in the care of the patients. And so interacting with them to try and understand the various elements of burden is quite a fruitful process that we've found. And then at the end, as we said, so linkage, important with these sort of patient to caregiver dyads, to think about the consent. So we've got consent from both the patients and the caregivers for linking the two parts of the data. Okay, and if you go to the final case study, this is a study in transfusion-dependent beta-thalassemia, sponsored by Bluebird, and we captured data from adults and caregiver proxies for the younger 12 to 17 year olds. So as with the other ones, it was co-created with patient advocacy groups and key opinion leaders across the different scope countries. Here it was US and Europe, and here it was actually, although it was longitudinal, it was daily data capture. So again, we had to be very careful about not being over ambitious in terms of the burden for caregivers and in terms of what we wanted them to do every day. We had some really great engagement in this study where we used a very tailored reward program to try and make sure we got that engagement over every day of the 90 days. Now, of course, you do get some attrition, you do get a little bit of drop off. We had some really strong engagement across that period. And if you want, you can look up for yourself the publication that came out of that. That you see the reference for at the bottom. So just very quick, 3 different examples of studies that we've done, quite different longitudinal or cross-sectional, different indications and different data capture. But as I suppose the common theme is really thinking carefully and engaging with different stakeholders at the beginning of the study, thinking about the research questions and how you're best going to do tailor the data capture to the situation, the indication, and of course not neglecting the other constraints that caregivers have upon their time in their daily lives.
Thanks, Mark. So in the interest of time, I'm just going to focus here on the challenges that we haven't necessarily touched on already in the discussion today. So some of the challenges that we have faced in our experience of conducting caregiver research, the first one is obtaining consent from both members of a pair. So we all know how challenging it can be to obtain consent from just a patient for a study sometimes, and you add in a caregiver as well. There are so many more additional things that we need to consider. So do we recruit the patient first and then the caregiver? Do we go the other way around and recruit the caregiver first and then the patient? We also need to think about confidentiality issues as well. So we need to make it very clear to both the caregiver and the patient that the data that they provide is not going to be shared with the other, and vice versa. You could imagine that as a caregiver, if you want to freely share how you're feeling about the burden of caring for somebody, if you knew information would then be fed back to a patient, you would probably be much more to provide a complete picture. So there are some practical considerations there. The ability to take part and participant attrition are linked. So we have experienced some situations where caregivers have registered interest to take part in a study, and then by the time we have come round to arranging data collection, so whether that's an interview or completing questionnaires, that caregiver has just been too busy. And so that's something which is really, really important to consider in study design. There are fluctuating care needs in the same way that there are fluctuating symptoms in some diseases for patients. So it's really important to be flexible and perhaps extend timelines for data collection in these types of situations. If it's an interview, allow time for scheduling outside of normal working hours, for example. Generalizability can sometimes be an issue. We encounter situations where, for example, if we're looking to talk to parents of children, of pediatric patients, we see situations where mothers most commonly care for children, but we want broader perspective sometimes than just the mothers. We want the father's perspective too, and so that needs to be taken into account in the study design. And then finally, just thinking about some of our top tips from our experience. So I think the first one, which is key, which we've already covered, is explaining the benefits to somebody of taking part. So these caregivers are usually very busy people. They have a lot of things that are a lot of demands pulling on their time, and actually explaining to them that taking part in this research could help people like them in the future can sometimes help them to be able to feel that they can prioritize this over other needs as part of their caregiving responsibilities. Make it easy to participate, avoid lengthy questionnaires, be flexible, consider allowing participants to pause during completion particularly if you've got a number of different questionnaires in a study, and allowing them to return. And then, as Mark said, making sure that we are involving caregivers in study design. We work very closely with patient associations, and we're thinking about developing study protocols and patient-facing materials. So thank you very much. I'll hand back over to Anna now to take us through the Q&A.
Thank you so much, Catherine. Okay, so we're going to start the Q&A now. I've seen questions coming in, and we had a few actually sent before the webinar as well yesterday. So we'll try and get through as many as we can. We are on a bit shorter time, but it should be fine. Hopefully we'll get through it. If we don't answer all of your questions today in this session, we'll follow up on email as well afterwards. So first question we've got here is, what are the different methods used to recruit caregivers into real-world studies?
I can start with that one if you want. Yeah, I can start with that one. So I would say it's very similar to patient research. So in the same way that you would consider a variety of options when you are designing a patient-reported study, you would also do this for a carer study too. So we have many of the same options for recruitment available to us. There's a huge spectrum, so they would vary from things like clinical site recruitment, so recruiting through clinical sites. We would see this particularly if we're recruiting dyads, so we typically recruit patients through clinical sites and then ask them to refer us to their caregivers. We commonly use what we call community recruitment methods, so that's working with patient associations, patient groups, to be able to recruit patients and also caregivers. Other methodologies include things like specialist recruitment agencies who hold panels of caregivers. We find snowballing is quite effective with our caregiver studies as well. So caregivers, particularly in rare conditions, are often connected to other caregivers who are in similar situations. So if our study design allows for this snowballing recruitment, that can often be quite helpful to us. And of course, there are advantages to each of those options.
Yeah. Okay, thank you. This might be one for Mark, but have you got experience measuring the cost of illness to caregivers?
Measuring what? Sorry, I didn't quite catch that.
Catherine. Sorry, have you got experience measuring the cost of illness to caregivers?
Yeah, I mean, our modelling teams, I mean, cost of illness studies, once you have established, you know, various of the components of burden can be a next step. So we have done that in the past. I don't know if Catherine, you've had any experience with that first steps, but yeah, I mean, it does take some time to do that. But as I said, what we've been talking today about mostly is really establishing the first point, which is a good understanding of the granularity of the burden, and then after that, laying on top of it, you know, costing measures in the relevant countries for those relevant domains.
Just to add to what Mark said, I think it's also important to define what we mean by cost. You know, cost can mean so many different things when we're thinking about caregiver burden studies. It could be healthcare system costs. You know, we talked about caregivers potentially becoming patients themselves. It could be work and productivity cost. It could be hidden out of pocket costs. You know, these are all types of costs that sort of lend themselves to very different study designs.
Okay, thank you so much. Can I just ask people who in there asking questions, could you just add your name to the question, just in case we don't get to answer everything during this session, just because we are a little bit tight on time, but and we can get back to you as well. So another question we've got is, do you have any recommendations for getting caregivers on board to help with study design or participation?
Perhaps I could take that. I mean, when we we touched upon the collaborative nature of the design process that we typically follow, I mean, we've found in the past that patient advocacy groups are a really strong starting point for that. I mentioned that often caregivers, with the caveat that they've got lots on their plate, are happy to be called upon, because often they haven't been called upon that much, and it's been an area of research that's been underrepresented. There's no magic formula for that, but it does take time, it does take resources. But yeah, patient advocacy groups, and explaining to them the point of the research you're doing. You know, usually this, in the studies that we've undertaken, caregiver research has been part of you know, understanding the condition better. The literature might not have been that good, and their voice hasn't really been heard in research before. So when we've presented the collaborative studies we're trying to do to them, and offered them means of engaging in the design process, and actually often engaging with other caregivers, perhaps in other countries as well, they find that can be quite a rewarding process for them as well. So we've had good experiences of doing that, but yeah, it really, I suppose it varies depending on the indication as well.
Another question for you here. What is the best way to communicate real-world evidence results on caregiver burden externally, and to whom and how, etc.?
I can talk to this one to start with. I think it's the short answer is that it's very different for different audiences. I think it depends on who you want to communicate this data to. So I guess we could start with a few examples from our studies. So typically in our studies, we would be looking to present this data, first of all, back to the carers who have taken part. So once that study's finished, first and foremost is about making sure that those results are communicated to those participants, and that could take a number of different formats. It could be a lay summary of the study results. It could be what we like to refer to as data nuggets. So that's sort of infographic type summaries of key statistics within that data set, things that participants would find particularly interesting. Then we've got clinical and academic type audiences. So studies would typically be written up as journal articles or published at conferences. We've published results from studies like this in disease-specific journals, broader HEOR-focused journals. It really depends on who it is that you want to be reading that data and that evidence. When we've worked with PAGs, we've made sure that that data has been communicated back to them. Again, that would be similar sort of lay summaries. It could be embedded on their website in patient and carer stories, for example. And then, of course, there's other key stakeholders, HTA, typically, so that could be carer, in this case, disutilities presented alongside patient utilities, or the data presented as part of that disease burden evidence. Mark, I don't know if you can think of any other examples of ways that we've presented our data.
Yeah, just one other aspect to mention is that often, as we've mentioned, we work in close partnerships with patient advocacy groups. So when they're partners for some of these studies, one of the things they often quite like to do is present some of the data at annual general meetings, for instance, back to the, that they have, back to their sort of network, if you like. So I think that works very nicely as a way of circling back and telling the participants and caregivers what progress has been made.
Great, thanks both. So another question here is, are there any differences between caregivers that we need to be aware of for study design? For example, taking into account age of patient, caregiver, relationship to patient, and how is it best to factor these into the study design?
I don't think relationship would have a huge impact on study design. I think unless you are recruiting a pediatric patient population and then looking to recruit their caregivers as well, there will be various aspects of consent and the practical process you'd want to consider. I think it's always good to know as part of the data set who that caregiver is, what's the relationship there. It helps to build up the picture of the people who would typically care for that type of patient. I guess if it's an adult patient, it might typically be a spouse. If it's a child patient, it's usually a parent. So there isn't a huge amount in our experience that varies in terms of the study design.
Okay, thank you. So we're technically over time, so I'm just going to throw one more in. So we've got a question here. Do you compensate the caregivers when they take part in a survey, and how?
Mark, do you want to take that one?
Yeah, sure. So broadly, I mean, it varies a little bit by study. With any compensation of participants in sort of any type of research like this, there's the notion of market value and not making sure that any incentives are consistent with their time broadly. So you shouldn't be giving too much, because that could be considered inducement, as I'm sure plenty of people are familiar with. Beyond that, we've the nature of engagement over time for longitudinal studies is really, really important. So caregivers, as with patients themselves, rewards and compensation can be a really, not the only part, but is a very important part of thinking about the patient and the caregiver value proposition, if you like, for participating in this type of research. So we have used compensation for caregivers in that situation, which could be either direct in the form of things like Amazon vouchers or equivalent, or donations to patient advocacy groups, for instance, or charities, which works extremely well. Okay, so we've come to the conclusion, based on quite a lot of experience, that those types of compensation mechanisms should be considered at least in the design of every study. Now, you might make a decision not to for various reasons, but we've seen really strong results, so that's why we advocate for that quite strongly. It has to be tailored to the study and the caregiver.
Fabulous. Thank you, Mark, and thank you everyone for your questions. We will follow up with all of them following this webinar, but we have sadly run out of time. We've eked over a little bit, so I'd like to thank you everyone for coming. And just to let you know, we actually have our next Keeping It Real number 6 webinar coming up on the 4th and the 5th of April, and it will be on generating real world evidence to support nice severity modifying modeling. So we'd love to see you there, and thank you again, and see you soon.